This is a patient referred with a 31.3 millimeter eye. She has a lens bag complex that is dislocated onto the retina. There's a lot of Summering's ring material in there, and she's very bothered by this. Here we're doing a pars plana vitrectomy with a chandelier light. We're cleaning up all the vitreous. You can see the trocar insertion in the upper left-hand portion of the screen. We're going very peripheral and very anterior, doing a complete vitrectomy. When this is completed, 360 degrees, and the core vitrectomy is done, I'm going to aspirate the lens bag complex off the retina, which is sitting way back there. I mean, this is really a big eye. We're going to bring this up, flip it over, bring it up. I'm going to hand it to myself and then hand it back to myself. Sort of a hand over hand technique, and then try to get this whole lens bag complex up in front of the iris where I can work with it and take it out. So now I'm going to inject some viscoelastic on top of this to protect the cornea endothelium. I've shut the infusion off while I cut. I'm cutting the lens 90% of the way through here. And once that's done, I'm going to try to cartwheel this old star 3-piece silicone lens out through the main incision. This half comes out first, and the other half remains. I'll go ahead and grab that and pull that out. The infusion is on now, and I'm going to burp the Summering's ring out. This is the capsular bag coming out first, and now the Summering's ring material remains, so we'll try to burp that out. A piece does fall back. We're going to have to go back and get that later. Here's one piece, and now the other piece, and this is mostly out. So now we're going to go ahead and get this piece of Summering's ring that's fallen back onto the retina. I'm cleaning up the particulate debris that's kind of floating around. And now I'm going to go back, aspirate this up off the retina. And I've switched to a vit frag mode, which is lower cut rate, higher aspiration. So I can crush this with the light pipe into the vitrector tip and aspirate this. I don't want to have to keep picking pieces up, so I try to hold it onto the tip of the vitrector as I do this. And this is successful. I've removed all this Summering's ring. We'll go ahead and do a little bit more cleanup here to make sure all this particulate debris has been cleaned out. And when that's done, we can go ahead and do the Yamane portion of the procedure. We're going to go ahead and remove this chandelier light because it will be in my way for doing Yamane. And when I pull this out, even though it's a 25 gauge trocar, there's a lot of leakage. And so I want to close that. I'm going to do a transconjunctival Tenno nylon suture, tie this tight. But still, there's a fair amount of conjunctival ballooning, and that's going to get my way doing the Yamane. So I'm going to just take that conjunctiva down to bare sclera so I have a little better control of the Yamane portion of the procedure, which is going to be a little tricky in this very big eye. So now I'm marking using the Ashwin Agarwal marker, and I'm going to bend my needle so the bevel is actually facing away from me rather than up. I think it makes the AR40 docking a little easier. These marks are placed 2.5 millimeters posterior to the limbus, but in this big eye, I want to make sure I'm away from the iris. The lens is injected. This is a 4 diopter lens, and its haptic length is a little bit larger, 13.5 millimeters in the AR40. This is an AR40. When you get under 6 diopters, they go up from 13 to 13.5 millimeters in length, which is really going to help us here with this big eye. I go ahead and do my first needle insertion, and there's some air bubbles I'll remove with the vitrector so I can see. Now you can see I'm docking the first haptic, and this slides in very nicely to this 30 gauge TSK needle. I'm going to drop the second haptic into the anterior chamber and let go of the hub of the needle so I can do the other side. I'm now making my second needle pass exactly 180 degrees away. This is a nice long pass of the needle through sclera, so I have a secure haptic fixation. I push the optic away with the tip of the needle so I can grab the haptic distally and that'll make it a little easy to insert into the needle tip. Here you can see the insertion is pretty smooth. There's no kinking of the haptic or forces placed on the haptic that would kink it. I'm now going to withdraw both needles at the same time, and both haptics do come out of the eye, but one of the haptic on the left side, remains subconjunctival. So here, this haptic is on surface. The other haptic, I'm going to have to cut down conjunctiva here so I can get to this haptic, which is sitting on the surface of the eye under the conjunctiva. And you can see these thick AR40 haptics really have a tight fit in these scleral tunnels. It takes some force to pull them out. I mean, they're really tight, and I like that. So now I just have to make a small melt here, just a little nubbin to make sure that it doesn't enter that scleral tunnel. It stays in position. There's a tiny little burn in conjunctiva, but that's no big deal. I melt the other side into a little flange. And again, you don't need a real big flange here, just a little flange to hold this in place. And you can hardly see these little flanges on the surface. The lens centers very well. I go ahead and inject Myocol to bring the pupil down. And now, it's very important to do a peripheral iridotomy with a vitrector. I like to do these temporally. This is a very long myopic eye. Without iridotomy, there's a risk of reverse pupillary block. But I like the lenses well centered and sitting a good distance back of the iris. We go ahead and remove our trocars, and one by one, we're going to place tenonylon sutures to close these sclerotomies securely. And then I'm going to rotate the knots so that they're in the sclera. I'll show that later. So here we place our second tenon nylon in the sclerotomy of the trocars. It's pulled. This is the final infusion line, and we're pulling that, closing the sclerotomy, and now rotating the knot into sclera so it won't irritate the patient. And the case is completed. Thank you for your attention.